systems.
Okay, so let's unpack this. We're going to cover, well, main parts based on our resources.
Mhm.
Cranial nerves, the motor system, sensory stuff, and reflexes.
And often starts right at the top with those 12 cranial nerves.
Right, the direct lines from the brain to the head and neck. Each one's got a specific job, yeah.
Precisely. Which means we have, specific ways to test each one.
Okay, let's dive in. Cranial nerve I, olfactory. That's smell, right?
Correct. Our material doesn't detail a specific bedside test for it, but its function is carrying smell information. Simple as that, well, functionally speaking.
Got it. Then, cranial nerve 2, the optic nerve. Seems like a big one for assessment.
Oh, definitely. We check visual acuity, how sharp your vision is, usually with a Snellen chart.
Like the eye chart at the doctor's office, the material mentions an example. 2025 left, 2015 right.
Yeah, and think about explaining that to a patient. What does 2015 actually mean compared to 2020? It means you see at 20 feet what someone with normal vision sees at 15 feet. So better than average.
Oh, okay. Better than 2020. What else for the optic nerve?
We check color vision, visual fields, that's your peripheral vision, and pupillary reflexes.
That's the pure RLA acronym.
Exactly. Pupils equal round, reactive to light and accommodation. It sounds simple, but it tells us a lot about the midbrain.
Wow. And then there's the fundoscopic exam.
Right, looking right at the back of the eye at the optic nerve head itself. It's like a little window into the brain sometimes.
Cool. Okay, moving on. Nerves 3rd, 4, and 6, oculomotor, trochlear, and Duson's, they're grouped together.
Yes, because they all control eye movements. They work as a team.
So problems would show up as like double vision or eyes not moving together.
Precisely. Difficulty tracking an object smoothly, or maybe an eye turn, those sorts of things. Very important for just, well, seeing the world correctly.
Makes sense. Next, cranial nerve V, trigeminal. You said this one does double duty?
It does. Sensory and motor for the face.
So how do you test that?
Well, for sensory, there's the corneal reflex. You touch the cornea gently, and the person should blink.
Yeah.
Yes, that's one branch.
Okay.
Then we test general sensation on the face, forehead, cheek, jaw, usually with a light touch like a cotton wisp. That covers the 3 main sensory branches.
The ophthalmic, maxillary, and mandibular branches, right?
Exactly. And for the motor part, we have the patient clench their teeth and we feel the muscles or ask them to open their jaw against resistance, testing those chewing muscles.
Okay, that cotton wisp gets around. Cranial nerve 7th, facial nerve.
Yeah, this is the big one for facial expressions. So assessment is mostly observation.
Like asking someone to smile, frown, raise eyebrows.
Yep. Puff out their cheeks, close their eyes tightly. We're looking for symmetry and strength. And it also handles taste on the front part of the tongue.
Interesting. Okay, cranial nerve 8th, vestibulocochlear. Sounds complex. 2 parts.
2 parts, cochlear for hearing, vestibular for balance.
So you test hearing, maybe with a whisper test or finger rub?
You can do basic checks like that, yeah.
Yeah.
And for balance, while a full vestibular workup needs special equipment, you can do some initial screens.
Right.
Things like the Romberg test we might discuss later.
Good to know. Okay, nerves 9X and X glossopharyngeal and vagus, often tested together.
Often together, yes. They handle functions in the throat.
Yeah.
We check the gag reflex.
Gently touching the back of the throat.
Right, with a tongue depressor on each side. And also the palatal reflex, checking if the uvula rises evenly when you stroke near it. We need to note if these are normal, reduced, or absent.
Important protective reflexes.
Yeah.
Got it. Nerve xlea, the accessory nerve.
This one controls key neck and shoulder muscles, the trapezius and sternocleidomastoid.
So testing involves shrugging shoulders and turning the head against resistance.
Exactly. We look for weakness and also for muscle wasting or atrophy and sometimes tiny twitches called fasciculations in the trapezius muscle.
Fasciculations,
Yeah.
like tiny muscle jumps.
Yeah, you might see them under the skin. Little involuntary flickers.
Okay. And finally, cranial nerve 12, hypoglottal.
All about the tongue muscles.
How do you test that one?
You ask the patient to stick their tongue straight out. If there's weakness on one side, the tongue will point or deviate towards that weak side.
Towards the problem side. Okay. Wow, that's a lot just for the cranial nerves.
It is, but it gives so much information about specific brainstem areas and nerve pathways.
Right. So after the cranial nerves, we move down to the motor system assessment.
Correct. Here we're looking at muscle, bulk, strength, and tone.
Bulk, meaning size?
Yeah, size and symmetry. Comparing muscles on both sides. A small difference, say under a centimeter, is usually okay. We're looking for noticeable atrophy, muscle wasting, or hypertrophy, which is unusual enlargement.
And strength. You mentioned a grading system.
Yes, a 0 to 5 scale.
Yeah.
It makes the assessment objective.
Can you run through that quickly?
Sure. 0 is no movement at all. 1 is a flicker of contraction, but no limb movement.
Hmm.
2 is movement, but only with gravity eliminated, like sliding your arm on a table.
Okay.
3 is movement against gravity, like lifting your arm up. 4 is movement against some resistance from the examiner. And 5 is full, normal strength.
That's clear. So 3 is sort of the basic functional level moving against gravity.
You could say that, yeah. And 5 is what we consider normal power.
What about tone? How do you assess that?
Tone is the muscle's resting tension. We feel it by moving the patient's limbs passively. We check if it feels flaccid, like limp,
No resistance.
right, or spastic, which is velocity-dependent increased tone, catches, then gives way, or rigid, where it's stiff throughout the movement, like bending a lead pipe.
Okay. And you also mentioned observing for tics.
Yes, noting any involuntary movements, where they are, how often, how fast, how big.
Gotcha. So after motor, where do we
Right.
go? Cerebellar function.
Exactly. The cerebellum is key for balance and coordination.
So checking how someone walks their gait.
Observing the gait is crucial, yes. We also check for drift, having them hold their arms out and seeing if one arm drifts down or away. And the Romberg test.
Ah, you mentioned that. Standing with feet together, eyes open, then close.
That's the one. If they're much unsteadier with eyes closed, it points towards a problem with proprioception, their sense of body position, rather than purely a cerebellar issue, usually.
Interesting distinction. And coordination test.
Yes, things that require smooth, controlled movements, like rapid alternating movements or rams.
Like tapping hands on thighs, flipping them over quickly,
Exactly. Or tapping fingers quickly. We also do point-to-point tests like finger to nose.
touching your nose, then the examiner's finger back and forth.
Correct. Looking for smoothness and accuracy, any tremor.
Yeah.
And the heel-to-shin test, running one heel down the opposite shin.
Okay, checking how well the brain coordinates everything. Now the sensory system.
Right. Evaluating different types of sensation.
Like pain and light touch. Using that cotton wisp again?
Yep, the cotton wisp for light touch, across different body areas comparing sides, and maybe something sharper, like a broken cotton swab stick, carefully, for pain or sharp dull discrimination.
What else in sensory?
Vibration sense, usually with a tuning fork on bony spots like the ankle or wrist.
Hmm.
Position sense, knowing which way we're moving a toe or finger with our eyes closed.
And more complex things too, like identifying objects by touch.
Exactly, that's stereognosis. Putting a familiar object like a key or coin in their hand and asking them to identify it without looking.
Okay. And tracing numbers on the hand.
That's graphesthesia. And then extinction testing, if they can feel touch on both sides of the body at the same time.
How does extinction work?
Well, someone might feel a touch on their left arm fine and on their right arm fine. But if you touch both arms simultaneously, they might only report feeling the touch on, say, the right side. The sensation on the left side is extinguished.
Wow, that's just a problem processing simultaneous information.
It often relates to parietal lobe function. Yeah. The material also mentions filament testing, which uses fine filaments to test protective sensation, especially important in conditions like diabetes.
Right. Okay, lastly, reflexes. Everyone knows the knee-jerk test.
That's the classic deep tendon reflex or myotatic reflex. But reflexes are more than just that. They're involuntary defense mechanisms.
You mentioned 4 types.
Generally, yes. Deep tendon reflexes, like the knee jerk or biceps reflex. Superficial reflexes, like the corneal reflex we talked about, or the abdominal reflex.
Stroking the abdomen lightly.
Yes. Then visceral reflexes, involving internal organs, like the pupil constricting to light parapara. And finally, pathologic reflexes.
Meaning abnormal ones.
Exactly. Reflexes that shouldn't be there in an adult or shouldn't behave a certain way. The main example is the Babinski reflex.
The foot one.
Right, stroking the sole of the foot. Normally, your toes curl down.
But with Babinski.
The big toe goes up and the other toes fan out. It's a sign of potential trouble in the central nervous system, specifically the upper motor neurons.
Okay. And for the regular deep tendon reflexes, there's also a grading scale.
Yes, similar to strength, we grade reflexes. Typically 0 to 4 plus COS. 0 is absent, 1 plus is hypoactive or diminished, 2 plus is considered normal.
And higher.
3 plus is brisker than average, maybe exaggerated, but still potentially normal for some people. 4 plus is very brisk, hyperactive, and usually associated with clonus.
Clonus. What's that?
It's like rhythmic, involuntary shaking or beating of the foot or wrist after the reflex is elicited. Just tapping a tendon might set off several beats.
Okay, so 4 plus with clonus is definitely not normal.
Generally indicates hyperreflexia, often seen with upper motor neuron issues. The resources also nod to the reflex arc, the basic neural pathway for a reflex.
It's amazing how much you can learn from these seemingly simple tests, and the sources link these skills to evaluating things like headaches, seizures, head injuries.
Absolutely. These physical exam skills are the foundation for diagnosing and managing a huge range of neurological conditions. Understanding how to perform and interpret them is just crucial.
So summing up, we've covered the assessment of cranial nerves, the motor system's bulk, strength and tone, cerebellar function like balance and coordination, the different sensory pathways, and finally, reflexes.
It's a systematic way to check the integrity of the entire nervous system, from the brain down through the spinal cord and out to the peripheral nerves and muscles.
When you think about all these different tests and what they reveal, it really highlights how incredibly complex and, well, intricate our nervous system is.
It truly does. The organization required for all this to function smoothly is just staggering.
So, a final thought for you, our listener. Considering this detailed neurological exam, what does it make you appreciate about the sheer complexity running things inside your own head and body every second? Definitely something worth pondering.